Greetings. Let us talk about acute kidney injury in a patient with cirrhosis. Whenever we see acute kidney injury in cirrhosis, we think about hepatorenal syndrome. But before we go there, let us talk about acute kidney injury. These are my acknowledgements. I thank support from many for making this possible. Please read this notice. So, when you see a patient with cirrhosis and ascites, especially refractory ascites, and when you look at their labs to assess their kidney function, you check the serum creatinine. This patient's serum creatinine on admission is 0.6 milligrams per deciliter. But when you come back to the rounds on day 2, about 2 days later, the serum creatinine has jumped from 0.6 to 9 milligrams per deciliter. Although the serum creatinine value will not have any highlight to say it is abnormal, in patients with cirrhosis, a jump of 0.3 milligrams per deciliter from baseline within 48 hours indicates acute kidney injury in a patient with cirrhosis and ascites. So keep this thing in mind. Whenever you see a jump of 0.3 milligrams in 2 days, that is acute kidney injury, even though the value appears to be within the normal range for your hospital. So important to keep this thing in mind because acute kidney injury increases morbidity and mortality of patients, and early intervention is likely to reverse this problem. So let us learn about different stages of acute kidney injury. And when it comes to that, in a patient with cirrhosis, we look at serum creatinine level. So we have already learned that an increase of 0.3 or more than 0.3 milligrams per deciliter within 48 hours is an indicator for acute kidney injury in a patient with cirrhosis and ascites. Another definition is a 50% increase from a baseline within the last 7 days is also another way to look at acute kidney injury in a patient with cirrhosis and ascites. So, in terms of the severity of acute kidney injury, there are 4 different stages. Acute kidney injury 1A is when there is an increase of 0.3 milligrams per deciliter or more, but less than twofold increase from the baseline, but the final value is less than 1.5 milligrams per deciliter. That is AKI 1A. AKI 1B is when the value increases to more than 1.5 milligrams per deciliter. So that is a little more advanced disease. So twofold is something to keep in mind when you're talking about AKI 1 and 1.5, less than 1.5 is 1A, more than 1.5 is 1B. So twofold. If it is 2 to 3-fold from the baseline, more than 2 to 3-fold, it is AKI 2. If it is threefold or higher, then AKI 3. Or if you have a serum creatinine of 4 milligrams per deciliter with an acute increase of 0.3 milligrams per deciliter, it is AKI stage 3. Or if the patient is on renal replacement therapy. So keep in mind two important factors. Even if there is a small increase in serum creatinine of 0.3 milligrams per deciliter in a couple of days, you should be suspicious of acute kidney injury. Whether it is AKI 1, 2, or 3, it's very easy. 1 is less than two-fold increase, 2 is 2 to 3-fold increase, and 3 is more than threefold increase from the baseline. So keep this thing in mind. Don't go by normal values. Look at the trend of serum creatinine happening for a few days. Even though the values look to be within normal range, it is still acute kidney injury in patients with cirrhosis if there was more than 0.3 milligrams per deciliter increase over 48 hours. So now, how do you assess acute kidney injury, whether in patients with cirrhosis or without cirrhosis? Keep this in mind. For the kidney to function, we need renal blood flow. And then once the blood goes into the kidney, it goes through the glomerulus, and then it goes through the filtration, comes down the tubules, and then once it is collected in the pelvis of the kidney, from there it is passed down the ureter. So there are three important reasons for acute kidney injury. If you just keep this thing in mind, you can assess any acute kidney injury in a very systematic manner. So let us look at blood flow. That is pre-renal because of decreased blood flow or low perfusion or hyperperfusion. This could happen because there's not enough effective circulating blood volume. In other words, hypovolemia. This can happen if the patient has had a bleed or the patient lost fluid because of excessive diuresis, or if the patient lost fluid because of either vomitings or diarrhea from the gastrointestinal tract. Hypovolemia is an important cause for hypoperfusion and prerenal reason for acute kidney injury. The other one is the volume looks okay, but the renal arterial system has gone into severe vasospasm, and renal arterial constriction decreases the flow to the glomerulus, and that is the mechanism for hepatorenal syndrome. We will learn about the mechanism for hepatorenal syndrome later on, but this is something to keep in mind. Another reason for low perfusion. So when it comes to the renal causes, in the kidney, you have glomerulus, you have tubule, you have interstitium. So keep those three things in mind. So you could have a tubular injury, that is acute tubular necrosis, or you could have interstitial injury, that is acute interstitial nephritis. Typical example is drug-induced interstitial nephritis, or it could also be infection, urinary tract infection. And then never forget that we start the filtration mechanism in the glomerulus of the nephron, that is glomerulonephritis. So the blood from the renal artery goes to the glomerulus, glomerulonephritis, tubule, tubular necrosis. Tubules are in the interstitium, acute interstitial nephritis, and urinary tract infection. So we talked about pre-renal causes, renal causes, and then Once the urine forms, as it comes down the ureter, you can have post-renal cause due to obstruction to the flow. In other words, urinary tract obstruction. In a male, it could be prostate hypertrophy, or it could be stones, or it could be cancer blocking the ureters. So these are all the mechanisms for acute kidney injury that are seen in any patient, and irrespective of whether they have cirrhosis or ascites, but the same mechanisms apply in patients with cirrhosis and ascites. So when there is a bump in the creatinine, think about these different mechanisms, take the relevant history to see if it is pre-renal, renal, or post-renal, and figure out about applying different diagnostic tests to establish the diagnosis. We will learn about it in the next lecture, and I would like to thank authors of these two beautiful papers. One is a guideline from the Liver Society, and another one is an excellent review on hepatorenal syndrome published in gastroenterology. Hope this is helpful. Thank you.